Chapter 3. COVID policies may have averted 200,000 COVID deaths in the U.S. Based on the comparison to Sweden and other countries that did not use a lockdown strategy to combat COVID, it may be that our lockdown strategy of issuing stay-at-home orders, mandating mask wearing, closing schools, closing churches, and closing restaurants and other businesses did not reduce COVID deaths at all. The lockdown strategy may have been no more effective in reducing COVID deaths than an alternative strategy of simply informing people of their risk based on their age and health status, informing people of the measures they could take to reduce their own risk, and then letting them modify their behavior as they see fit, with no mandatory restrictions at all. But logically, the lockdowns must have reduced COVID infections and reduced COVID deaths somewhat. That was presumably the intent of the strategy. So how much might the U.S. strategy have reduced COVID deaths? First, to estimate how many deaths our strategy might have prevented, we need to know what percentage of the population has been infected, and then the infection fatality rate, IFR, or percentage of infected people who die. We know how many people have died of COVID, the numerator of that fraction, but we do not know as accurately how many people have been infected, the denominator. To determine how many people have been infected, the best method is to conduct a seroprevalence survey, collecting blood from ideally a random sample of the population and assaying the blood or plasma for antibodies against the SARS-CoV-2 virus. The assumption is that if anyone has been infected, he or she will have raised antibodies to the virus, and the antibodies will be detectable months or years later. The best COVID seroprevalence study I am aware of in the U.S. involved collecting plasma from dialysis patients nationwide in early July 2020 and testing over 20,000 of them for COVID antibodies. Anand et al. The result was that 8.0% of the samples were positive for COVID antibodies, and after adjusting from the age, demographics, and zip codes of the patients to the age, demographics, and zip codes of the U.S. as a whole, the researchers arrived at a conclusion that 9.3% of the U.S. population had been infected as of early July 2020. Anand et al. It takes about 10 days after infection to develop antibodies, so I consider that to be the infection rate as of July 1, 2020. It takes about 2 weeks after infection on average for people to die of COVID if they die from it. So to calculate the IFR, I am using the deaths as of July 15th to compare to the infections as of July 1. On July 15th, 2020, we had 140,775 COVID deaths in the United States, which, if 9.3% of the population of 328 million was infected as of July 1, gives an IFR of 0.46%. That 0.46% IFR should be viewed as probably an upper estimate of the IFR in the spring wave of COVID, because the data from Anand et al. Is more likely to underestimate the infected population than overestimate it, for two reasons. First, we know many infected people never raise detectable antibodies, Burgess et al. And second, one would expect dialysis patients, since they are rather sick, to be more careful to try to avoid COVID infection than most people, and therefore to have a lower infection fatality rate than the general infection rate rather than the general population. Also, other researchers have calculated a 0.2% IFR in Los Angeles County, Sood et al. We had 140,775 COVID deaths as of July 15th, 2020, and we have 574,025 as of April 8th, 2021. If the infection fatality rate per infected person has remained constant in that time at 0.46% as of April 8th, 2021, 37.9% of the U.S. population has been infected. It is a 4.08-fold increase in deaths, and if we multiply 9.3% times 4.08, the result is 37.9%. In fact, we know the infection fatality rate has been lower in the fall-winter wave than it was in the spring wave of 2020. In New York City in the spring, 27% of hospitalized COVID patients die, whereas now only 3% do. For Minnesota, I calculate from the state health department numbers, 36.3% of hospitalized COVID patients before July 15th died, and since then it has been 21.9%. Also, 3.9% of laboratory confirmed COVID cases in Minnesota died before July 15th versus 0.93% since then. The reasons COVID is getting less deadly is, first, the medical community is learning what treatments work and what do not, and it has some new treatment tools, including serum of recovered patients and monoclonal antibodies. And second, the virus is mutating to forms that are at least slightly less lethal. From an evolutionary standpoint, the virus does not care whether it kills us. It just wants to spread. So it has an evolutionary interest in becoming more contagious, but none in becoming more lethal. And we know the mutant forms are becoming more common, are more contagious, but at least a little less lethal. So the IFR was 0.46%, or perhaps a bit less in the spring of 2020 wave, and less since then. Overall, 0.40% is a reasonable estimate. Using the 0.46% IFR in April 2021, we have 37.9% of the US population already infected. If the IFR is 0.40%, then it is 43.8% of the population infected as of April 8, 2021. The percentage of the US population that has been infected by SARS-CoV-2, the virus that causes COVID-19, up to April 2021 is about 40% then. The most our strategy could possibly have achieved is preventing the other 60% of the population from being infected. Obviously, that is not the case, and if it were, it would mean we will have no cases or deaths going forward. In fact, if our strategy were able to stop all infections, we would have never had an epidemic. A fairly generous estimate would be that the lockdown strategy has prevented and will prevent about 15% of the population from being infected. Almost half as many as have already been infected, which would prevent 200,000 COVID deaths. 15% of the US population is 49 million people. If the infection fatality rate is 0.40%, preventing 49 million infections prevents 197,000 deaths. How many COVID deaths is it possible the lockdowns have prevented? Another way of looking at this is to ask, if we were at herd immunity in the US, how many COVID deaths would we have? The worst we could have done if we had not done lockdowns is to get to herd immunity. R is the average number of people an infected person transmits the infection to for any contagious disease. And R0 is the special case of R at time 0, when the population is naive and every person the infected person encounters is non-immune. For COVID-19 and SARS-CoV-2 infection, R0 was estimated as 2 to 4. As more people become infected and immune, R drops over time. Also, R is dependent on human behavior as well as the biology of the virus, and the point of the lockdowns and physical interventions like masks, hand washing, and social distancing is to reduce R. When R falls below 1.0, meaning the average person infects fewer than one new person, the epidemic dies out, although you can still get some new cases, and you have reached herd immunity. It is estimated for COVID-19 that we need to have 70% or at most 80% of the population infected to get to herd immunity. If R0 is 4, then in principle, if 3 out of 4 people are already immune, then R has fallen by 4-fold from R0 of 4 to a current R of 1.0. By that calculation, if R0 for COVID was 4, which was the highest estimate, then you need 3 of 4, or 75% of the population infected to get to herd immunity. The US population is 328 million. 70% of that would be 230 million, and 80% would be 262 million. I calculated above the infection fatality rate, or IFR, or percent of infected people who die, was 0.46% in the spring wave and somewhat lower than that in the fall-winter wave. Overall, it has been about 0.40%. For 230 million people, 230 million infections, 0.40% would be 920,000, and 0.40% of 262 million would be 1.049 million. In other words, if the US were at herd immunity, the epidemic would be over, and we would have about 1 million COVID deaths. Instead, as of April 8, 2021, we were at 574,000 COVID deaths, and the University of Washington model predicts we will be at 600,000 on June 1, 2021, with almost no deaths after that, and the only deaths after that point being persons who chose not to be vaccinated and accept the risk, as is their right. So the most COVID deaths and the lockdowns could possibly have prevented is 400,000. The difference between the 1 million deaths we would have were we at herd immunity, and the 600,000 we actually will have before we have vaccinated everyone at risk who wants to be vaccinated. Yet another way of looking at this is to look at the worst COVID death rates in the world and consider that the worst we could have done in the absence of lockdowns is to be there. Among nations with populations of 1 million or more, the most COVID deaths per million population is Czechia at 2,575. Among U.S. states, the most are New Jersey at 2,790 and New York at 2,631 as of April 8th, 2021. So no nation or U.S. state will get to 3,000 deaths per million. If the U.S. were at 3,000 deaths per million population, that would be 984,000 COVID deaths. Again, very close to 1.0 million. So from two angles, we reached the same conclusion that 1.0 million total COVID deaths, or 400,000 more than we will actually get, is the worst we could have possibly done if we had not done lockdowns. Therefore, the most COVID deaths the lockdowns could possibly have prevented in the U.S. is 400,000. Conclusion. The most COVID deaths the lockdowns could possibly have prevented in the United States is 400,000. The Sweden comparison suggests the lockdowns may not have actually prevented any COVID deaths at all, and as we will see in a later chapter, all the evidence indicates that is about right. A generous but not unreasonable estimate would be that the lockdowns have prevented 200,000 COVID deaths in the U.S., which also happens to be half as many as the most they could possibly have prevented.